For our first talk of Bridging the Gap 2025, we have Professor and Dr. Jürgen Beck, Director and Chair of the Department of Neurosurgery at the University of Freiburg in Germany. And I'm the patient moderator for this section. My name is Jen McKenzie, and I'm a recovering PDPH patient after having a very long-term spinal CSF leak, it was eventually repaired through surgery. And I'm currently volunteering on the board of directors at the Spinal CSF Leak Foundation. Dr. Beck, we're very glad to have you here today presenting on such an important topic as PDPH. Please begin when you're ready.
So good morning, everyone. I hope you can hear me, you can see me, and if all good. So first of all, I would like to thank Andrew McCallen and the Spinal CSF Leak Foundation for making this possible. I'm very honored and very proud to be here in this. I always call it a family with the colleagues and also the patients, and that we have so much time to spend this whole morning or afternoon in Germany with some conundrums and some progress we have made in spinal CSF leaks. This is Freiburg and Black Forest. This is our medical center where we have the benefit to have all necessary specialties, neurology, neuroradiology, and neurosurgery in one building. And this is what you can see here. The topic is about post-dural puncture headache, but of course has a lot in common with spontaneous intracranial hypotension. And both diseases or both disorders are primarily orthostatic headache disorder, as you can see here. And despite the common clinical presentation, of course, we have to take into account that it is the etiology is different. So in post-dural puncture headache, we have always an iatrogenic needles that entered intendedly or unintendedly the thecal sac, versus in spontaneous intracranial hypotension, the disease starts spontaneously. And if you look at the definition of the International Classification of Headache Disorders, it is still a little bit neglected, or because there is no such a thing as a persistent or a chronic post-dural puncture headache. Currently, it is defined that after dural puncture, intendedly or unintendedly, if you get headaches within 5 days after lumbar puncture, and this is then caused by CSF leakage, please keep that in mind, we come to that back later. And then you have post-dural puncture headache, and usually it should stop after 2 weeks or earlier after sealing with an epidural blood patch. So what our patients, what many of you and many of us physicians are dealing with, is not really defined in this, at least not in this. I still have some problems here. In this International Classification of Headache Disorders. So. Okay. But of course, we do see many patients with chronic or persistent post-dural puncture headache. And not only that we see these patients, or not only that you are affected with this disorder, there is a growing body of literature and evidence that this disorder does exist. And that as well, it is possible that the onset of the disease is later than 5 days after dural puncture. And of course, that symptoms might very well be prolonged and last longer than 14 days, or last even after a blood patch. So on the other hand, it is a quite severe disease, and it is accompanied with a lot of signs and symptoms that might change a little bit over time. It's different immediately after lumbar puncture, intended or unintended lumbar puncture, where you have clear orthostatic headache and neck pain and tinnitus. And then it's changing a little bit in more, fatigue or reduced quality of life, symptoms that resemble depression, and even severe sequelae like subdural hematomas. And if you ask the patient group, it's a severe disease, and it's changing completely their current life. And it's patients and affected patients lose their jobs, lose their families, lose their joy of life. So it's a full spectrum of a severe chronic disease. One thing I have learned in this family, in the spinal CSF leak family and professional community, that it does matter with what kind of needle you are, as a physician, you are taking when you do an intended lumbar puncture. And it really does make a difference if you look at the tip of these needles, whether it's beveled and it's sharp, or whether it's kind of a pencil tip needle where the opening is at the sides of the cannula and not at the tip with a sharp edge. This is nicely demonstrated here that it does make a difference whether you enter the thecal sac with a pencil tip or with a sharp tip where you cut out a piece of dura and the remaining hole is way smaller in a pencil tip needle than in a beveled sharp needle. And this is supported by numbers now, so you can reduce the number of a post-dural puncture syndrome from 11% to 4.2% by just using the modern appropriate needles that are not beveled at the tip, that are pencil-like at the tip. And this has been validated and again put into a nice paper that needle type has a high level of certainty that we can harm our patients using these sharp beveled needles, and as well as the size of the needle. So it's rather simple. The smaller, the better for preventing post-dural puncture headaches and post-dural puncture syndromes. This is a aggressive looking image, but this is just the form of the beveled cannula that has entered the dura, is nicely depicted by electron microscopy, that you can see when the needle is sharp, you do more harm than when you use a blunt pencil type needle. Again, there's more and more data that also this chronic or persistent form of post-dural puncture headache exists. And this is not a real systematic overview, but it's just what we encountered 2 or 3 years ago. We just put together how severely affected our patients are. On the one hand, it's clearly there's a huge bias because we are a referral center, and patients that are severely affected come from all over Germany, Europe, and the world to our place in Freiburg. But on the other hand, you can clearly see it is not a harmless disease. These patients have been on sick leave for over a year on average, have seen at least 5 doctors or hospitalized in at least 5 different institutions, and have been even 1 month in acute hospital care. This is another paper that shows how severely affected post-dural puncture patients are. This is a survey Ali Kappan has made and published in Headache last year. And don't focus on the single numbers. It just gives you an overview that once you are affected with this post-dural puncture syndrome, the capacity to do your job full-time in the same job, in the same work you have been before, is only 12%. So roughly only every 10th patient can return to his same job. Or to put it in another very impressive number, the ability to take care of your own children the whole day, only 12.8% of the affected patients were able to do that. Something that is known up to now is where does it come from? How do we approach patients after intended or unintended lumbar puncture? And there was this arachnoid bleb sign. This is a very subtle sign that you can see here where the arrow points to, and this in the sagittal MRI, you have this small, tiny little bleb. And this is really something that does exist. This is a case here with 1, 2, 3, 4, 5 blebs. And all these blebs really have been some forms of leak locations once we did surgery on this patient. On the other hand, another sign that has been proposed and propagated is the so-called dinosaur tail sign in patients, even when the MRI of the brain looks normal in patients after post-dural puncture, that there is these white structures here that we have to make it more visible here with the red dots. These are some structures, some fluid structures that accumulate here beneath the ligamentum flavum and make the sagittal spine look like the tail of a dinosaur, as it was put in the publication of Sakurai in Headache 2017. This is where the name of this sign comes from. It's just should resemble the tail of a dinosaur. This is why it's called the dinosaur tail sign. And this is supposed to be more prevalent in post-dural puncture. But to to give you our impression, it is not. So this is just experience based up to now, but the dinosaur tail is very, very often present in completely healthy patients, even in individuals that never have seen a dural needle or underwent a dural puncture. So this is not a very good sign. But now coming to the new evidence that is available, and Andrew has asked me to report a little bit about two papers that have been published recently, one's about imaging and one about CSF dynamics. What's really going on? What do we see on imaging when we have a post-dural puncture patient, and what really is going on in the CSF system? What about the pressure and the CSF dynamics? Of course, thanks to my team, we are able to produce these data and to produce these numbers, and also thanks to all the patients and families and caregivers that have been involved in these studies. Without you, that would not have been possible. Give you some numbers now. So Charlotte Sander was very clever to put this together. What is actually going on imaging if you have a post-dural puncture headache? And this was a general overview, and of course also utilizing the burn score, just because to have a uniform language all over the world where the burn score is used. How does this relate to post-dural puncture? The burn score is now kind of a standard in spontaneous intracranial hypotension. So how does it look like in post-dural puncture syndrome? And unfortunately, there is not much going on. So you can have a completely an MRI that completely looks like a SRA, a CSF loss syndrome, with a large pituitary, downward displacement of the brain, sagging of the brain, enlarged venous systems, and you can have a completely normal MRI in post-dural puncture. Though this is striking, and there's a big difference as compared to SIH. And this is probably one of the main messages of my talk, is that a normal brain MRI does not rule out post-dural puncture headache syndrome. This is just, for instance, as an example given to patients both after peridural anesthesia while labor, and one MRI is clearly positive and one is clearly negative. And unfortunately, in PDPH, most of the scans are negative. Um, so, but we also, Charlotte Sander and our team also looked at the spinal findings, and this is very interesting because there's what the crime scene happens, so to say, where the action takes place, and unfortunately, you don't see much of evidence of CSF leaking either. But if you look clearly here, you have a kind of a ventral. This is the ventral side. These are the spinal vertebrae. This is the spinal cord. This is the CSF space that is normal. And here in front of it, you have a ventral a fluid deposit outside of the thecal sac, which is clearly pathologic. Here now shown with the red arrows. This is CSF where it does not belong to. This is a positive spinal MRI. And this now is the corresponding post-minor CT. And you can see here this cap of white stuff here. This again is contrast medius. So this is CSF outside of the thecal sac. But interestingly, not here where the spinal needle enters during the lumbar puncture, but on the other side, on the ventral side. Okay. And this is, or this was, these are now clear numbers. This was positive in our study, which included, I think, almost 100 patients, 88 or 90 patients, in 12% of patients with post-dural puncture headache. This is an overview over the results of the study. So as I've shown you just in a second before, epidural fluid was present in 12% of the patients, and interestingly, only at the ventral side, so opposite to the side where the spinal needle enters the thecal sac. There was not one case, not one MRI where there was clear free fluid on the dorsal side of the thecal sac. And the other striking finding is that, as opposed to spontaneous intracranial hypotension, where we have a high burn score, where we have a lot of signs that Walter Schieving has described, and others, brain sagging, enhancement of the meninges, we can clearly find in most of the patients with spontaneous intracranial hypotension, it's the other way around in post-dural puncture headache. So the burn score is very low to, if we exclude these positive patients, rather 0.9 or 1, so rather normal. Meaning, is post-dural puncture headache an MR diagnosis? No, it's not. This is really, I think, a clear message and a strong message. In most patients, you don't see it on imaging, neither on brain imaging nor on spinal imaging. And put it in other words, does a negative imaging rule out post-dural puncture headache? No, it does not. A negative imaging, a negative MRI does not rule out post-dural puncture headache or syndrome. So this is also reflected in what anesthesiologists currently propose. So it's not a imaging diagnosis, it's a clinical diagnosis. But on the other hand, do we image or shall we image patients with this syndrome? Yes, of course we shall, especially in this group of patients and doctors and caregivers in some specialized centers where patients approach us, what's going on now. Of course we shall image because if there are atypical symptoms, and by definition, symptoms longer than 14 days are atypical symptoms. So if a chronic PDPH develops, and of course in CSF centers, and even if you consider surgery or even surgical exploration, you do need an MRI of the spine and the brain. And one finding, again, that was also present in this study was arachnoid blebs. They've been present in the study of Charlotte Sander in 9% of the patients. So it's rather also a little bit disappointing that we have probably one clear sign, but we had a very well-defined cohort of almost 100 patients with post-dural puncture headache, and only 9% we did find an arachnoid bleb that looks like that. This was the very spot of the bleb on imaging. Now you can see here that the CSF is oozing out next to the bleb and washing away the blood that it has accumulated. So we called it weeping dura, that you can remember very easily. So this is a clear sign on imaging, but unfortunately, it's only positive in 9% of our patients. Now switching to the CSF system, to the CSF dynamics, we utilized a procedure that was invented in the 1970s in kids in the pediatric population for hydrocephalus. And this is the measurement of how the system reacts to a volume load that is injected into the spine, into the spinal dura. So once you insert the needle into the thecal sac and you start infusion of ringer or saline here, there's an increase in the slope, in the pressure that we can measure with the same or a second needle until it reaches a plateau. So this is a normal reaction, this is a normal curve, and this was used heavily for diagnosis of normal pressure hydrocephalus or hydrocephalus in kids. And we transferred this 2017 to spontaneous intracranial hypotension. So this is now spontaneous cerebrospinal CSF leaks, and you can clearly see again this normal curve, as I have shown you a second ago, and a clearly different looking curve, completely pathological shaped curve. This goes for spontaneous intracranial hypotension, and it kind of makes sense if you have a system with a hole in it, that it reacts differently to a fluid, to a volume overload. And we wanted to test this in post-dural puncture as well. Of course, how does it look like? And just to give you some numbers for the spontaneous CSF leaks, so there was a clear benefit. The false negative rate was clearly lower than in just regarding the opening pressure, and the area under the curve for the resistance to CSF outflow was increasing our diagnostic accuracy. And it was investigator independent and showed a specific pattern of CSF dynamics once the dura has a hole in it. And the RCSF out, or resistance to outflow, was the best diagnostic parameter. But, and this was very interesting in 2017 already, when we first tested it, there's a clear difference whether you test patients acutely, subacutely, meaning within 1 year, or even later than 1 year. So, and if you looked at the numbers, again, this only goes for spontaneous spinal CSF leaks in the acute phase, meaning less than 10 weeks. Everything is straightforward. The resistance is very low pathologically. After 10 weeks, it's 50-50, and after 1 year, more patients do have an increased resistance to CSF outflow, despite having still an open hole in the dura. So this is tough to grasp, but these are the results. And this gives us a clear time dependency, the same data just shown otherwise. So in the acute phase, you have 5 as the threshold. You have a very pathological threshold in the acute phase. In the subacute phase, it's rather normal. And in the chronic phase, it's even resembling patients with normal pressure hydrocephalus. So nobody is really knowing what's going on. But please keep this in mind when we now interpret the data for post-dural puncture headache. Timing does matter. So time matters for spinal leaks. And this was also true for treatment that you do. If you treat patients with spontaneous leaks early, you have a very, very high chance of completely resolve the symptoms. And if it's done years or decades after it, the chances are lower. So now the interesting stuff for chronic post-dural puncture headache, we did kind of repeat the same study now in patients with post-dural puncture headache and not with spontaneous CSF leaks. And we were able to include 21 patients, which is quite a lot because, as you can all understand, if you are affected by a disorder that has changed your life completely after someone stuck a needle in your dura, we want to we repeat this using smaller needles, but we want to repeat this. So it's we were lucky that a lot of patients agreed to do that, and we have data for 21 patients now. These are the numbers. And symptom duration is important, as I've shown you. So 21 months. So this is a real chronic patient group. And again, as in Charlotte Sanders' youngest publication, almost all these patients had a normal brain MRI and a normal spine MRI. Again, repeated, imaging does not rule out post-dural puncture headache. If you don't look at the numbers in detail, too many, but the striking results are that the RCSF out is 10.7, the lumbar pressure at opening is 9 millimeters of mercury, equaling 12 or 13 centimeters of water. So this is just normal. All these numbers are normal. So to show you in a more simple way, in a graph, both the lumbar pressure and the RCSF out of severely affected patients with post-dural puncture syndrome was normal. No change, no decreased lumbar pressure, no elevated or decreased resistance to CSF outflow. It's striking and unexpected, but these are the numbers, all normal. So we cannot use CSF testing to rule out or to rule in chronic post-dural puncture headache. Or to put it in other words, with this study, and this is the gold standard in infusion testing, we were not able to find any pathologic changes in post-dural puncture headache. What can we learn from this study? It's a single center, small study, but at least with our system, chronic post-dural puncture headache does not seem to be related to a measurable, this is important, a measurable CSF leak, a CSF leak that we can measure with this system. It is not related to low CSF pressure or CSF depletion or to reduced outflow resistance. And again, like in Charlotte Sanders' study, there was no leak visible on imaging. So seems to be a problem, but if you look into the literature, there is also already a study from the 1950s and then repeated in 2019 that in PDPH, it does not appear that there is a different or decreased opening pressure and no change pressure volume index. So do we really have a CSF leak disorder then? This is the question. And we have to be careful with interpreting this study. And I think there is a wonderful editorial in the study was published 2025, a couple of months ago, and by a wonderful editorial by Jeremy Cutsford-Gregory, and he nailed it down, so to say. So what we can learn is that we cannot tell from one study that PDPH is not to active CSF leakage. Probably we can say it's not gross overt CSF leakage because we don't see it on imaging, and we don't have different CSF dynamic results. So this is not let's say a massive amount of CSF that is leaking, because this you would have seen with our CSF study and with imaging. And probably we can summarize it that despite these patients have symptoms and all the signs, we can currently not identify with our methods that this is normal. So probably our study methods are not sophisticated enough at the moment. And this means that, like imaging, a normal CSF opening pressure, not just the CSF dynamic studies, just an opening pressure does not rule out PDPH. And a low burn score or a normal brain imaging or also a normal spine imaging does not rule out PDPH. And as Jeremy nicely put it in the editorial, we still should continue with blood patching as early as possible. And so what's going on there? And there was the first report from Russell McRoberts over 100 years ago in JAMA that, of course, there should be something going on at the dura when you stick a needle in. And he kind of initiated this, that it is a leaking syndrome. And once the hole in the arachnoid is at the very same spot as the hole in the dura, then we have a CSF leak syndrome and post-dural puncture headache. Okay? We couldn't really corroborate that, neither on imaging nor on CSF dynamic studies. But there is still something going on. And this is also a comment from Jeremy Cutsford-Gregory in the editorial, which is very, very sophisticated, I think. And probably future work, he says, will demonstrate structural or functional remodeling of the dura that occurs over time, that perpetuates the orthostatic headache in our patients. And I think these are two very important issues or points, that it is a structural thing of the dura and timing is so important. There is evidence that very early after post-dural puncture, in the first days, so to say, you clearly find positive imaging. And but this is changing over time, and we need to look more closely what's going on there to help our patients. And this shifts a little bit the concept of McRobert from the CSF leaking to more a kind of a arachnopathy or duropathy that is evolving over time. Timing is so important. So to elaborate on this, what else do we have? What else can we see? And we have, of course, some surgical findings, since in the most desperate patients, we, after an MDT decision, we never do this alone, we explore these patients surgically. And we do this minimally invasively in Freiburg over a small incision, and we use this tubular retractors, and we always do these days a 3-level approach, because you're never really sure where the needle hit the dura, where the lumbar puncture was. And these are some results of our surgical findings. And I think it's very valid to look at the surgical findings to try to understand the pathophysiology of this disease and what's going on. And of course, again, we have this arachnoidal blebs you've already have seen, and I show you some videos from the surgical exploration. And this is one striking feature. This is what we call neomembranes, and this is never ever the case in a normal spine. And I've did many spine surgeries for lumbar disc herniations and in tumors, so on, so unrelated to CSF, and not in one instance I found these sticky neomembranes only in CSF patients, meaning in SIH patients and in post-dural puncture patients. I do find these membranes. So there is something going on that you probably do not understand at the moment, but there is a pathological change of the dura. There is the duropathy, so to say. And once these sticky membranes are removed, underneath there is this tiny little bleb that you see in imaging that is clearly oozing out, probably to an extent that we cannot measure with our CSF testing, but there is clear oozing. Whether this suffices for causing symptoms, we do not know, but it's clearly pathological. And probably it is the same mechanism in these tiny little blebs as we have described in 2016. My group has shown this in 2016, that in spontaneous intracanal hypertension, there's a dural tear. It's on a macro level. There's a huge bleb herniating out. Probably this is arachnoid, and the oozing happens next to the diverticulum, to the dural tear. And probably this is the same on a microscopic scale. So this is just less than 1 millimeter, that there is a kind of a bleb, and the CSF is oozing out next to the bleb, to the still not healed, still open dural tear induced by a spinal needle in that case, in post-dural puncture headache. And under these membranes, this is just another case. This is the membrane, and under these membranes, we found these open tiny holes, a millimeter or so, just at the size of the needle that we closed. And we also found, again, sticky membranes, several needle holes. So this is one, this is another one, this is another one. So we have 3, 4. Probably it's too bright, but we have 3 or 4 clear incision needle holes with beveled needles that are persisting in post-dural puncture headache, covered by membranes that we can see on surgery. A very important finding for the prognosis of our patients are these tiny little ventral leaks. Probably you can see it here. This doesn't belong here, and this is not on the dorsal side, it's on the ventral side. So meaning the spinal needle was penetrated through the ventral and through the dorsal aspect of the dura to the whole thecal sac on the other side. And when you find this in post-dural puncture headache, this is now, you can probably see it more clearly with the red arrow. If you find this, you are kind of have some luck in this poor situation, because the prognosis is way better. In all our patients, we found this ventral leak in post-dural puncture headache. We opened the dura. These are again sticky neomembranes on the dorsal aspect. We still opened the dura and went all the way through the rootlets to the ventral aspect of the dura. And I show you, this is the dorsal aspect. We opened the dura, and now we are on the ventral side, and you have this clear. Now I'm in with the hook, with the dissector. You have this persisting hole on the other side of the dura. And once we encounter this, we are quite happy, because we can suture this easily, and the prognosis is quite grim in PDPH, but all these patients that have a ventral leak are doing very good, very good. So they have a good prognosis. Again, several arachnoid blebs that we found, that corresponding surgical images. We can take care of this during surgery. And there's also another mechanism with these blebs that I would like to show you, that during surgery, and I think it's important to look at these surgical findings, because we haven't understood the disease. So probably this gives us some insights that there is a tiny little vein really connected to that bleb. And probably you can see it here. This is a venous vessel, a vein that is sticking to the dura, and you have to cut it sharp to dissect it from the dura. This is not normal. This does not happen normally. And probably this is also one mechanism how the CSF, here I need to cut it, and then I can close it. Yeah, and underneath there is this bleb that was under the vein. Most likely here you can see it once the vein was removed, most likely the entry point of the spinal needle. So this might already also explain why CSF testing is negative, because the amount of CSF that is, so to say, withdrawn by the body to these tiny little holes is probably too small to be detected by our CSF infusion testing. This is just more of the same stuff. These are just changes that we can see during surgery. To summarize these findings, so we have clear pathological findings once we explore post-dural puncture headache patients. They have blebs, they have a weeping dura, there can be single or multiple needle holes. So all these attempts to penetrate the dura have been successful and have left some scars on the dura. And from the prognosis point of view, once we find this ventral leak, so on the ventral surface of the dura, the prognosis after surgery is quite good. Then we find these all kind of sticky membranes, sticky translucent membranes, or that's sometimes we call it a web pattern, because there are a lot of vessels in it. And once we open it, only below these membranes, the normal dura appears, sometimes with a hole, not always, sometimes without a hole that we can find. Sometimes it's more vascularized, sometimes not, but there's clearly something going on, and I've never found these patterns in non-CSF or non-PDPH patients. So this is something where we need to concentrate on in the future if we want to understand this disease in more detail. These are numbers from our center. on Freiburg. So these are real numbers. So in percentages, this is 100%. So in almost all cases, we find neomembranes, only in half of them arachnoid blebs and puncture holes, and in only 10% ventral holes. Unfortunately, these are with the best prognosis. And this is very important that I don't pretend to have a solution. Even after surgical removal of the neomembranes, not all of our patients are getting better. So surgery for post-dural puncture is still not a solution for everyone, and the success rate is not so good. So only 20% are really healed, so to say. They are really clearly getting better. 40% are getting better with still some remaining symptoms, but 20 to 30% do not improve after surgery for post-dural puncture headache, and 5 to 10% even get worse. So this is currently not a solution, and we still need to do this in centers and only based on MDT decisions. So if you ask me what is PDPH now, it is imaging negative, is a CSF study negative. Um, I don't know the answer, but if you ask me to speculate, I speculate about an arachnopathy, a duropathy, a membranopathy that is probably leading to a soft oozing or a subtle CSF loss syndrome that we cannot see on imaging and that we cannot measure, but is still related to CSF, and it's still related to CSF loss, probably in a more subtle way, and has a lot to do with arachnoid and duropathy. It is clearly not a benign disease. The sequelae are severe. It is currently, I think, best managed in specialized centers and in international collaborations. And like in this meeting today, thanks to the Spinal CSF Leak and to the Colorado University and Andrew Callen, we are able to talk about this and probably to find solutions and do better studies. And to give you my perspective in Freiburg, so if we do surgery in PDPH patients, we only do it after a multidisciplinary treatment team decision. And then the principles are to resect the pathological membranes, to always respect the arachnoid. I think this is key for this disease, to try to restore the arachnoid and to restore the anatomy and rebuild the layers and augment the dura. And of course, there is more work that we are obliged to do. Imaging in the clinical spectrum, targeted treatment, and also for supportive treatment. And we try to form a register currently now in Freiburg and in Europe. And I can only invite patients to participate and colleagues to participate. And of course, we need more long-term follow-up and outcome evaluation. And we really should tackle this. This was a slide. I took a photograph this year of the European Neurology Conference. These are striking numbers: $1.7 trillion on the dollars, euros, healthcare costs from neurological disorders in all over Europe, and 50%, 48% driven by headache disorders. So it's worthwhile doing this. And again, thanks to my beautiful team in Freiburg, and thanks to your patience and to the audience and to Andrew and the Spinal CSF Leak Society. Thank you so much.